Welcome to the podcast, everyone. Let's dive into sepsis and septic shock, starting with how these conditions are defined and why they matter so much in critical care.
Absolutely, there's a lot to unpack here. So, sepsis is now defined as a life threatening condition due to the dysregulated host response to an infection, leading to organ dysfunction, right?
Yes, exactly. And septic shock builds on that, where you see circulatory, cellular, and metabolic abnormalities, fluid refractory hypotension that actually requires vasopressor support, plus evidence of tissue hypoperfusion with raised lactate levels.
It's like the condition escalates into a full blown systemic catastrophe when the body can't maintain circulation despite fluids.
Right? And that's what makes early detection so crucial. The literature notes that early identification and management, like within that critical first hour, can really change outcomes.
Speaking of early identification, the screening tools come into play, don't they? Tools like SEERS, QSOFA, News, and Muse are employed to spot sepsis quickly, although they each have their strengths and weaknesses.
Exactly. Each of them has its own balance of sensitivity and specificity. For instance, SARS has high sensitivity but modest specificity, while QSOFA tends to be the reverse, easier to use and a bit more specific.
Yep. I have to ask though, isn't it a bit risky to rely on any one of these tools as the sole indicator? Guidelines advise against that, right?
You got it. The Surviving Sepsis campaign actually recommends not using just a single screening tool because of the variability in their performance. It's a combined approach in practice, along with clinical judgment, that really strengthens the early diagnosis.
Right? And that clinical judgment is so critical because sepsis can present so non-specifically, ranging from hyperthermia to hypothermia, agitation, even altered mental status.
Exactly. Let's consider the epidemiology for a moment. Worldwide, we're looking at around 20 million cases a year, but that's likely an underestimate, especially in low-resource settings.
Sadly true. And roughly a third of those cases occur post-operatively, with sepsis being the leading cause of death among adults in ICUs. That's staggering.
It is staggering indeed. When you're dealing with such numbers, you have to respect the gravity of the condition. Plus, septic shock has an in-hospital mortality rate estimated between 35% to 54%, with annual mortality figures possibly over 5 million.
Those stats really drive home the importance of not just early detection, but also robust initial management.
Exactly, and that's where the treatment guidelines come in. The standard approach now is the Sepsis Hour 1 bundle, which includes rapid assessment of lactate, drawing blood cultures before antibiotics, and starting broad-spectrum antimicrobials almost right away.
Yeah, right. And don't forget about fluid resuscitation, administering 30 ml/kg of crystalloids as quickly as possible. Fluid management really is a cornerstone of therapy.
Absolutely. It's like performing an emergency balancing act. You want to restore preload and oxygen delivery, but then you have to be cautious about the risk of volume overload.
So person 1, why do you think balanced crystalloids are preferred over, say, unbalanced ones like normal saline?
Well, balanced solutions like Ringer lactate or plasma light have an edge because they better maintain the body's electrolyte balance and reduce the risk of acidosis. Normal saline, while commonly used, can sometimes lead to hyperchloremic acidosis if administered in large volumes.
That makes sense. And then, when fluids alone aren't enough, we move on to the next step, vasopressors. The guidelines clearly advocate for starting norepinephrine as the first-line agent.
Exactly. Norepinephrine is initiated typically between 2 to 5 mcg per minute, titrating to reach that target mean arterial pressure of at least 65 mmHg. And if norepinephrine alone isn't sufficient, vasopressin or even epinephrine can be considered.
Right. I find it interesting how the guidelines stress switching to central venous access for vasopressors as soon as possible to reduce complications. What are your thoughts on that?
It's definitely a critical point. Starting vasopressors peripherally can be necessary initially, but central line access minimizes the risk of tissue necrosis, and other local complications. It's all about balancing urgency with safety.
Absolutely. And then, let's talk about antibiotics, another pillar of sepsis management. The guidelines underline the importance of administering broad-spectrum antimicrobials promptly, ideally within 1 hour after recognition.
Right, because every hour of delay beyond that significantly increases mortality risk. And remember, blood cultures should be drawn before starting antibiotics, but not at the expense of delaying treatment too long.
It's a tightrope walk. Getting those cultures for proper identification versus starting treatment to control the infection.
Precisely. And speaking of identification, source control is another essential aspect. Whether it's draining an abscess or removing an infected device, it needs to be done within 6 to 12 hours of diagnosing sepsis.
Yes, adequate source control can really tip the scales towards patient recovery.
And then there are the adjuvant measures, like the use of corticosteroids in cases where fluid resuscitation and vasopressors aren't enough.
Yes, right. But I'd like to respectfully challenge one point. Some critics argue that routine use of corticosteroids might not be necessary in all patients. What's your take on that nuance?
That's a fair critique. The guidelines do specify that initial IV hydrocortisone should be reserved for when fluids and vasopressors fail to restore stability. It's not a blanket recommendation. It's more of a targeted approach for those with refractory shock.
That targeted approach reflects the delicate balance in modulating the inflammatory response without overusing steroids, right?
Exactly. And further adjuvant measures include respiratory support using low tidal volume ventilation strategies in case of ARDS, stress ulcer prophylaxis, and even thromboprophylaxis. The guidelines really cover every angle of care.
There's a lot that goes into managing the multi-organ impact of sepsis. For instance, the clinical presentation can be so diverse. Tachypnea for the lungs, hypotension for the cardiovascular system, and altered mental status for the brain.
Yes, and that's why dynamic assessment is so important. Tools like capillary refill time, lactate clearance, and even point-of-care ultrasound help guide reassessment and further intervention.
Yep, it really comes down to iteratively reassessing the patient's response to interventions, avoiding both underhydration and overhydration.
Absolutely. And to echo that, each step, from the immediate fluid resuscitation to vasopressor support and antibiotic administration, is a race against time. Even a marginal delay in any of these can contribute to increased mortality.
And let's not forget, the guidelines emphasize reassessing fluid balance within 3 hours of initiation, using metrics like urine output and dynamic blood pressure responses. That's crucial in patients with comorbid conditions like heart failure or renal disease.
Exactly. It's all about tailoring the treatment to the patient's current status while following protocols designed to reduce the high mortality risk, which can be as high as 40% for septic shock.
What a comprehensive approach. The integration of early recognition, fluid management, appropriate antibiotic use, and timely source control really sets the standard for managing this overwhelming condition.
No doubt about it. It's a multi-pronged battle that requires vigilance, rapid action, and continuous reassessment. Ultimately, awareness and timely interventions are our best weapons against sepsis and septic shock.
Agreed. It's a tough fight, but these guidelines offer a roadmap to navigate through the complexities, ultimately aiming to save lives.
And that, folks, is why staying updated on the latest research and recommendations is so vital in critical care. The evolving definitions and management strategies remind us that medicine has to be agile and responsive to new evidence.
Right, absolutely. In wrapping up, it's clear that effective management of sepsis and septic shock hinges on early, aggressive, and well-coordinated treatment strategies. Kudos to all the research and clinical teams out there working on these life-saving protocols.
Well said. Thanks for joining this deep dive into sepsis and septic shock management. Stay vigilant and help spread awareness so that more lives can be saved in the battle against this critical condition.